Assalamualaikum everyone. My name is Areez Shafqat. This lecture is going to be on bile and fat digestion. And I always like to begin with sort of a big picture slide of what this lecture is trying to teach you. Um, so what this lecture is about is basically how you digest fat. As you know, in your diet, you ingest macronutrients like carbohydrates and proteins and fat. Carbohydrates, you guys know, is digested by salivary and pancreatic amylase. Proteins are digested by pepsin, which is released by parietal cells in the stomach. Pancreas releases trypsin and chymotrypsin and carboxypeptidases, which digest proteins. But fats are a bit different because fats are hydrophobic or water insoluble, which means that they like to aggregate together. So let me give you an example. If you've just eaten a meal of a plate and there's some oil on the plate, a lot of that oil always gets back together, collects back together. Fats are the same. So fats always like to coalesce or aggregate or collect together to form a big droplet of fat. And that big droplet is difficult to digest. So what your body does is release a thing called bile, which helps you digest fat. So I'm going to show you here. So let's say this is a fat droplet. It's quite big. It's difficult to digest because it's hydrophobic. When your stomach contracts, and your stomach, as you know from your gastric emptying lecture, your stomach contracts and releases food through the pylorus into the duodenum, which is now called chyme. And that mechanical force on the fat droplet, it breaks up that droplet into smaller pieces, right? So there was a big droplet and now it's smaller pieces. But what would happen in the duodenum if there was no bile? Because these fat droplets are hydrophobic, they would reform a big fat droplet. So they would reform this big thing here. And again, this is difficult to digest for pancreatic lipase. So what your body does is release bile. And what bile does is surround these little droplets in like this. All right? So that's what bile does. And it prevents these little droplets from coming back together and forming a big droplet of bile. This process of separating fat droplets into smaller droplets and preventing them from coming back together, this process is called emulsification. Okay, so that's the first function of bile, emulsification. Then, let me just erase this. And now these small droplets are easy for pancreatic lipase to digest, right? So now the pancreas releases lipase, which digests these small droplets because they're easier to digest now. And then the products of fat digestion, let me just draw them like this. Each droplet is now broken up into even smaller pieces, fat digestion. Then bile surrounds these droplets of fat, all right? So the fat has been digested, bile surrounds it. These two are called micelles, all right? So the first function of bile was emulsification, this process here. Then when that fat has been digested by lipase, then bile also surrounds those digestion products. And these digestion products here, these are called micelles. Micelles are basically like taxis. So they carry the fat digestion product from the lumen or the inside of the duodenum to the cell, to the enterocyte. And fat then gets absorbed into the enterocyte. Does this make sense to everyone? Can you repeat it quickly? Okay, no problem. Sure. So I was basically explaining the function of bile. So what we started off with is with explaining that fat is hydrophobic. That means fat always likes to collect together and aggregate or collect together or coalesce. And this forms a big fat droplet. Like this droplet is quite big. This droplet is very difficult for pancreatic lipase to digest. So what happens is when the fat is emptied from your stomach into the duodenum, it's in little pieces because of the mechanical force of the stomach, right? These little pieces, if nothing happens to them, they'll just collect back together to reform this big droplet. So what your body does is secretes bile into the duodenum. Bile then surrounds these small droplets. And this prevents these small droplets from coming back together. This process is called emulsification. That's the first function of bile you need to know. Now, these small droplets are quite easy for pancreatic lipase to digest. The pancreatic lipase digests them and breaks them up into hydrolytic products of lipid digestion. And now you need to absorb them. So what bile does is surround these digestion products. The digestion products plus the bile is called a micelle. These micelles basically carry these digested lipids to the enterocyte where they can be absorbed. Right? So those are the two functions of bile you need to know. Emulsification for making it easier for pancreatic lipase to digest, then micelle formation, which helps in lipid absorption. Does this make sense to everyone? Yes or no? You can type in the chat or you can unmute if you have a question. All right. All right. So someone asked, where are the micelles? The micelles would be here. After the fat has been digested, the bile surrounds the digested lipid and forms the micelle. The micelle is in the duodenum. It basically carries those digested products to the enterocyte for absorption. Now this should make, now I'm about to tell you something important that you should remember, and it should make sense to you, that bile is water soluble, right? So the outside of bile is water soluble. That's important for you guys to know. Someone asked the question, when the bile is secreted, does it surround the fat particles before lipase breaks them further? Yeah, because lipase can't break the big droplet of fat. Bile needs to surround them to make them smaller, and then lipase can act on them. All right. So now it should make sense to you now what I've written here. Fats are hydrophobic and are digested by pancreatic lipase. However, they aggregate and to form large droplets, which are difficult to digest because of a low surface area. Bile increases surface area for digestion by pancreatic lipase. This process is called emulsification. Bile then surrounds these digested products to form micelles. Micelles ferry or carry lipid digestion products to the enterocyte for passive absorption. So these are the two functions of bile. Now, there's a third function you need to know. Bile also contains bicarbonate, which aids pancreatic bicarbonate in neutralizing gastric acid. So when the stomach empties, the acid is obviously going to go into the duodenum. But the duodenal mucosa is not adapted to deal with that gastric acid. It needs to neutralize it. So what bile does, bile contains bicarbonate. Pancreatic juice also contains bicarbonate. These will come into the duodenum and neutralize the gastric acid. So now you have three functions of bile: emulsification, micelle formation, and bicarbonate, which aids in neutralizing gastric acid. Okay, so I would like to start off again this lecture by reviewing a bit of normal anatomy. So this is the liver. This is where bile is produced. Okay, bile is not produced in the hepatic, in the biliary ducts or in the gallbladder. Bile is produced by the liver in hepatocytes. Bile is then secreted into ducts, which this is the right hepatic duct, this is the left hepatic duct. These two join together to form the common hepatic duct. Here's the gallbladder with the cystic duct. The cystic duct and common hepatic duct join together to form the common bile duct. The common bile duct joins the pancreatic duct and empties into the duodenum. This is controlled by the sphincter of Oddi here. All right, so release of pancreatic juice and bile into the duodenum is controlled by the sphincter of Oddi. Please repeat the last function. Bile contains bicarbonate and the pancreatic juice contains bicarbonate. This allows them to neutralize gastric acid because acid is coming from the stomach into the duodenum. The duodenum needs to neutralize that acid. So bile contains bicarbonate, which neutralizes the acid. All right. Now, I would like to, we'll discuss it later on in the lecture, but I would like to just overview this right now so you guys have an idea of this later on. So as you know, your body likes to deal in feedback loop, right? So if there is a stimulus, your body will do something which will deal with the stimulus. So let's say gastric acid is coming into the stomach, into the duodenum. In the duodenum, there are S cells. They release secretin. Secretin stimulates bicarbonate secretion in the biliary ducts and pancreatic bicarbonate secretion. This bicarbonate goes into the duodenum and neutralizes the acid. So that's one feedback loop you should be aware of. Acid comes into the duodenum releases secretin. Secretin stimulates bicarbonate secretion in bile and in the pancreas, and this bicarbonate neutralizes the acid. So that's one feedback loop you should be aware of. The second feedback loop is something called CCK or cholecystokinin. When fat comes into the duodenum, it stimulates eye cells in the duodenal mucosa to release CCK. CCK stimulates pancreatic enzyme secretion and bile release into the duodenum. So CCK will cause gallbladder contraction and relaxation of the sphincter of Oddi. So this will cause pancreatic juice and bile to come into the duodenum and digest food. So digested food comes into the duodenum releases CCK. CCK activates the pancreas and bile to digest the food, and it relaxes the sphincter of Oddi, allow both to come into the duodenum. All right, so these are two feedback loops you should be aware of. Now we can start with the actual lecture. Bile is again secreted by hepatocytes. It's modified by cholangiocytes. So these cells, so when bile is secreted into the biliary ducts, these ducts are lined by cholangiocytes. These will add bicarbonate. So let me ask you now, which hormone will cause cholangiocytes to add bicarbonate to the bile?
Secretion.
Secretin, exactly. Because secretin is responsible for dealing with the acid. All right. Then bile now goes down these biliary ducts and reaches the sphincter of Oddi. But when you haven't eaten a meal, the sphincter of Oddi is closed. And so bile backs up into the gallbladder. The gallbladder will store the bile and it will concentrate the bile. So it will absorb sodium chloride and it will absorb water. This will allow bile to get concentrated. The actual bile salt will get concentrated. Then, when you eat a meal, the gallbladder will contract and the sphincter of Oddi will relax to allow bile to move out into the duodenum. Which hormone is mediating these two processes?
CCK.
CCK, exactly. So now this is, Dr. Peter just reviewed the function of bile. Bile acid aid lipid digestion by emulsification. They aid lipid absorption by formation of micelles. The third function is bicarbonate secretion, which aids in the neutralization of acidic gastric contents. All right. Now we look at the constituents or the makeup of bile in a bit more detail. Bile is made up of organic and organic constituents or organic stuff and electrolytes. The most abundant content of bile is something called bile salts. All right. So when I'm referring to bile later on in the lecture, I'm actually talking about bile salts, right? Bile also contains bilirubin, which is a yellow pigment. You should remember that for jaundice because we'll discuss jaundice later on. Bilirubin is a yellow pigment in bile. Bile also contains cholesterol, and bile also contains phospholipid. Lecithin is another name for phospholipid, right? Then bile also contains these electrolytes, sodium, potassium, calcium, chloride, bicarbonate. These are not important for you to know. All you should know is that, and this should make sense to you, that bicarbonate in bile is higher than it is in plasma. Bicarbonate concentration in bile is higher than it is in plasma. All right? Because as you know, secretin stimulates bicarbonate secretion. Now let's talk about biosynthesis. Again, when I'm saying bile, I actually mean bile salts. All right? I'm not talking about bilirubin or cholesterol or phospholipid. Bile salts, which is the most abundant constituent of bile. So you synthesize, the first thing you need to know is that bile or bile salts are made from cholesterol, right? So cholesterol is the precursor for bile salt formation. The first step, you have to know this, is called 7-alpha hydroxylation. This is the rate limiting step, all right? So cholesterol is in hepatocytes. Hepatocytes will hydroxylate that cholesterol by an enzyme called 7-alpha hydroxylase. What is, okay, thank you. Cholesterol will get hydroxylated by 7-alpha hydroxylase, which is the rate limiting step. This will form cholic acid and cheno-deoxycholic acid. These are primary bile acids, okay? These are primary bile acids. Now, I've written here up in the title, Dr. Peter wrote this, which is de novo synthesis of bile acids by hepatocytes. How you can think of this process is basically finding a way to make cholesterol water soluble. Because in that little diagram I drew for you, I told you that bile actually surrounds fat and solubilizes it. That should, now you have to know that bile salts are therefore water soluble. Cholesterol is not water soluble. So how will you make cholesterol water soluble? That's basically the process which hepatocytes are going through. They're making cholesterol water soluble and hence this is the process behind biosynthesis. It's basically a process of making cholesterol water soluble so it can surround those fat droplets and aid in their emulsification and micelle formation. All right. So as you can see here, Dr. Peter wrote this increases water solubility, hydroxylation, because this forms a carbon and oxygen bond, and these bonds are charged, which means they're polar, right? Which makes the molecule ionized. The next step, the first step was hydroxylation. The next step is conjugation. Conjugation basically means adding a glycine or a taurine to cholic acid and chenodeoxycholic acid. So this also makes them more water soluble. And this means they are mostly ionized. All right. Now, this is an explanation, it's a bit tricky, but I think it's better for you guys to know it. So I'm just going to explain it to you. Does anyone know what pKa means from biochemistry? Dissociation constant. Okay. So in simple words, pKa is basically the pH, the pKa of a substance is basically the pH which that substance wants. All right. The pKa of a substance is basically the pH with which that substance wants. Now, let me give you an example. Unconjugated bile acids have a pKa of 5. This means that they want the pH of the solution to be 5. Now, duodenal pH is usually 5, all right? Now, this is the acid dissociation equation, right? HA goes to A minus plus H plus. Let's say we're talking about taurochenodeoxycholic acid. It has a pKa of 1.5. The duodenal pH is 5. That means that the duodenal pH is higher than the pKa of this substance here. Okay? So when pH is greater than pKa, that means the solution is more alkaline or more basic than taurochenodeoxycholic acid wants that solution to be. Does that make sense? So if duodenal pH is 5 and taurochenodeoxycholic acid pKa is 1.5, that means this substance wants the pH to be 1.5, but it's actually 5, which means it's higher than this substance wants, or it's more alkaline. So what will this substance do? It will move this way. It will, the equilibrium of its dissociation equation will move this way, produce more acid. But now this is more ionized and it's charged, which means it's water soluble, right? So does that make sense? It's a bit tricky, but does that make sense to everyone?
Can you repeat the last point?
Sure. So we started off by explaining that pH is that pKa is the pH which that substance wants. The pKa here is 1.5. The actual pH is 5, which means the pH is higher than pKa. This means that the pH is more basic than the pKa or more alkaline than the pKa. This will affect the dissociation constant here. The equilibrium of this equation will move this way to release hydrogen to try and bring the pH back down. This means that the acid will be in the ionized form, which means it's more water soluble. This is in line with what I told you guys earlier, that the whole reason for that the whole reason behind synthesizing bile is trying to make cholesterol more water soluble. This is in line with that principle that we established previously. All right?
Makes sense. Thank you.
Thank you. So can you repeat it? Can you repeat? All right. You don't need to know this. You don't need to understand this well. All you need to know, with the presence of A minus, it becomes more water soluble. Yes, it does, because A minus means it's charged. Anything which is charged or has a negative charge or a positive charge is polar, is osmotic, it's water soluble. This here is non-polar. That means it's less water soluble. All right. So the reason for hydroxylation and conjugation is to make bile acids more ionized and more water soluble. That's the main thing you guys should know. Where does this occur? In the bile, in the hepatocyte, because the hepatocyte is the place of biosynthesis, right? I told you that hepatocytes synthesize bile and then they release it into the bile ducts. All of this is happening in hepatocytes here. right? Now let's imagine that you've hydroxylated cholesterol and you've conjugated the bile acid. So now you have the primary bile acid and you've released it into the duodenum. They did their job, they emulsified fat and they formed micelles, and now the fat has been absorbed in the enterocyte. What happens with bile now? Bile keeps moving down the intestine, down the small intestine, through the duodenum, through the jejunum, until it reaches the ileum. And then it moves out into the colon, where the first part of the colon is the cecum, right? In the ileum, there are bacteria which will deconjugate and dehydroxylate the primary bile acid. Now these are called secondary bile acids, right? So primary bile acids are synthesized by the hepatocyte by hydroxylation and conjugation. Secondary bile acids are made by bacteria by dehydroxylation and deconjugation. So basically a reverse of the process, right? So if the rationale for making primary bile acids was trying to make them more water soluble, the reverse of this, to make secondary bile acids, will basically result in making bile less water soluble or more lipid soluble. This means they're easier to absorb because lipid soluble substances can pass directly through the cell membrane. So that's why bacteria actually deconjugate and dehydroxylate bile to make it easier for your body to absorb them, for your ileum to absorb them. These deconjugated and dehydroxylated secondary bile acids will get absorbed by passive diffusion in the ileum. So yeah, so someone asked, could you please repeat? All right, secondary bile acids formed from primary bile acids or from bile salts. Now, all right, so this is a primary bile acid, right? And we said this is ionized, it's charged. You see a negative charge here, a negative charge here. This means that sodium, which is positively charged, attaches here and attaches here and forms a non-covalent linkage between these two substances. Anything with sodium, so an acid attached to a sodium, is called a salt. Sodium glutamate or glutamic acid, which you guys studied in biochemistry, when it's attached to sodium, it's called sodium glutamate. That is a salt. Primary bile acids, when they attach to sodium here, they form biosalts. All right. So primary bile acids, when they attach to sodium, they form biosalts. So when I say bile acids and biosalts, they basically mean the same thing. The only difference is that there's a sodium here and there's a sodium here. Okay? Does that make sense? Could you please repeat? What do you want me to repeat specifically? Will the bile acid become biosalts? Yes, they will. When they attach to sodium, basically, because they're ionized, right? So yeah, bile acids do form biosalts. Exactly. All right. Now let's talk a bit more about micelles. So now bile acids have been conjugated, hydroxylated, they're water soluble, they're in the form of bile salts, right? In the ileum, we make the secondary bile acids non-polar. Yeah, exactly. So these secondary bile acids are non-polar because now the bile has done its job and it's easier to absorb. So you want to make it easier to absorb. You dehydroxylate and deconjugate. All right. Now let's talk a bit more about micelles. All right. Someone's messaging one question. Bile salts have no sodium. They do have sodium, right? So an acid, for example, glutamic acid, which is an amino acid, glutamate, when it attaches to sodium, it's called sodium glutamate, monosodium glutamate, and that's the salt, right? So acids, when they're attached to sodium, they form salts. All right. So now let's talk a bit more about micelles. Now the bile is in the duodenum, is doing its job, right? So bile, what you should know about bile is that it's amphipathic because it's water soluble on the outside. Hydrophilic groups are pointing up out into the solution. The hydrophobic groups are pointing inwards, where the fat digestion products are, because fat is hydrophobic. The fat you ate is hydrophobic, so it is in the inside. With micelles, their hydrophobic portions are pointing inward, interact with those hydrophobic lipid digestion products. The hydrophilic portions are pointing outward. All right. Also, one very important thing you need to know is that cholesterol, which is a normal component of bile, is not amphipathic. It doesn't have both hydrophobic and hydrophilic parts. It's only hydrophobic. And so cholesterol is found in the inside of my cell. Now you've synthesized bile, and now you need to secrete it into the bile ducts, right? The left hepatic duct, right hepatic duct, common bile duct. Now you've made the bile, you need to secrete it. So now these are bile. This is reabsorbed bile, which is coming back from the ileum. It comes in, it can either be conjugated or deconjugated. The deconjugated will get conjugated. So all the bile is now conjugated. Now, bile acids are secreted into the bile canaliculi by a protein called bile salt export protein, which is an example of active transport. Cholesterol, phospholipids, these are all also secreted in here, into the canaliculi. Can you please go slower? Okay, no problem. So you're reabsorbing bile in the ileum. That bile is coming back to the liver cell, to the hepatocyte, and is getting absorbed here. All right. Some of it is conjugated, some of it is unconjugated. The unconjugated one will get conjugated to make it more water soluble. So now all the bile acid you have is conjugated. All that conjugated bile acid is secreted into the canaliculus between hepatocytes by a protein called bile salt export protein. All right. Cholesterol, phospholipids, lecithin, these are also secreted in here into the canaliculi by other transport mechanisms. You don't need to know that. All you need to know is bile is secreted into the canaliculi by a protein called bile salt export protein, which is a primary active transport mechanism. All right. Now, bile is now in the ducts. It's traveling through the bile ducts, and the cells which line the bile duct are called cholangiocytes. Okay. So this is a cholangiocyte. This is a cell lining the bile duct. All you need to know here is that the bile duct cells or cholangiocytes can secrete bicarbonate into the bile. Someone said that secretin will stimulate this. So this is the mechanism of secretin. Secretin binds its receptor and increases cyclic AMP inside the cell. This increases surface CFTR, which is a chloride channel. Chloride then moves out into the lumen or into the bile duct, and is then exchanged for bicarbonate here. So as a result, bicarbonate is the one moving into the lumen. All right. Water, because bicarbonate is charged and you're moving bicarbonate into the lumen, water follows bicarbonate here. So the result is more alkaline and more dilute bile. So again, let me just repeat it quickly. Secretin binds to its receptor and increases chloride transport into the bile. The chloride is exchanged for bicarbonate. Because you're pumping ions into the bile, this is obviously going to attract water as well. This means the bile becomes more dilute and more alkaline in the bile ducts. Does that make sense to everyone? Okay.
Yes, sir. Thank you.
No problem. Now, as we said, when you haven't eaten a meal and bile is traveling down the bile ducts, it obviously is going to run into a closed sphincter. So it's going to back up and get stored in the gallbladder. Now, after meals, the sphincter of OD will open because of CCK. The gallbladder will contract and it will push bile into the duodenum. The next slide will focus on what happens to bile in the gallbladder. All right, so this is the gallbladder cell here, the gallbladder epithelium. All you need to know here is that gallbladder is responsible for concentrating bile. So sodium is absorbed for hydrogen, exchanged for hydrogen. Chloride is exchanged for bicarbonate. So hence you're absorbing sodium chloride, and water will go where sodium goes, right? So water will also get absorbed. So you're absorbing sodium chloride and you're absorbing water. This means that the bile salt is actually getting concentrated in bile in the gallbladder. Does that make sense to everyone?
Yes.
All right. Now let's talk a bit more about the action of CCK. We talked about CCK, that it causes gallbladder contraction and relaxation of the sphincter, and it causes pancreatic enzyme secretion. Are we absorbing sodium chloride into the interstitium? Yeah, and then it's going to go into the bloodstream, right? Because there's blood vessels here, so sodium chloride is going to go into the bloodstream. Now, we talked about how CCK acts, but you need to know some of the mediators through which it acts. So CCK is secreted by eye cells. CCK binds to receptors on the vagus nerve. This causes the vagovagal reflex, and the vagus nerve releases acetylcholine onto the gallbladder. This causes gallbladder contraction. The vagus nerve also releases nitric oxide and VIP on the sphincter, which causes relaxation. All right. So the major action of CCK is through a vagovagal reflex. The vagovagal reflex will increase acetylcholine release at the gallbladder, causing contraction, and increasing VIP and NO release at the sphincter, causing relaxation. CCK also has a direct effect on the gallbladder, but this is quite minor, all right? So it has a direct effect and an indirect effect through the vagus nerve. The effect through the vagus nerve is the major mechanism, okay? Now, bile is regulated through phases. So in your gastric secretions lecture, you talked about phases of gastric acid secretion, the cephalic phase, the gastric phase, and the intestinal phase. It's the same with bile. You have a cephalic phase where you smell and taste the food. This increases vagal outflow. It increases vagal outflow on the gallbladder, i.e., what neurotransmitter will be released here at the gallbladder? Can you remind me from the last?
Acetylcholine.
Exactly, yeah. And here is VIP and NO, nitric oxide and VIP. So this will increase vagal nerve outflow, increasing gallbladder contraction and relaxing the sphincter of Oddi. Then comes the gastric phase. This gastric distension or stretching stimulates enterochromaffin cells to release 5-hydroxytryptamine or serotonin, which causes a vagovagal reflex. This will also act on the gallbladder, increase acetylcholine release, and relaxes the sphincter by nitric oxide and VIP release. The intestinal phase is when fat enters the duodenum and stimulates eye cells to release CPK. CCK causes a vagovagal reflex, which increases acetylcholine to cause gallbladder contraction and releases nitric oxide and VIP at the sphincter of Oddi to cause relaxation. CCK, as we said, also has a direct effect on the gallbladder, but this is minor mechanism, all right? So in the exam, what they could give you is an MCQ, something like what mediates or what is responsible for the cephalic phase of bile acid secretion. You would say the vagus nerve, all right? And what is responsible for the intestinal phase? CCK. Can you repeat the gastric phase? Sure. Gastric phase is basically when food enters the stomach, it causes distension. That distension or stretching, that releases serotonin onto the vagus nerve, the receptors on the vagus nerve, it releases serotonin. That serotonin stimulates a vagovagal reflex, which increases acetylcholine at the gallbladder, causing contraction, and VIP and NO release at the sphincter of Oddi, causing relaxation. So every single phase has the same mediators. Acetylcholine at the gallbladder, VIP, NO at the sphincter, all right? Just the stimulus is a bit different. For the cephalic phase, it's smell and taste. For the gastric phase, it's stretching. For the intestinal phase, it's CCK, all right? Now, we talked, comment, all right. Now, we talked about how bile functions. Now bile has done its function. It's emulsified fats. The fats have been absorbed in my cells by the enterocyte. Now the bile is traveling down the small intestine and it reaches the ileum. The bacteria will deconjugate and dehydroxylate the bile, the primary bile acid, to form a secondary bile acid like we discussed. And this basically makes the bile acids more lipophilic. And lipophilic bile acids are absorbed by passive diffusion in the ileum and in the colon, all right? Because lipids can easily pass through the cell membrane. The cell membrane is a lipid bilayer, right? So anything which is lipid soluble can diffuse into the cell membrane. Anything which is water soluble has to have a transporter for it. There are some, which is shown here, there are some bile acids which aren't deconjugated, all right? So they are absorbed by co-transport with sodium, all right? Apical sodium bile acid transporter. They're absorbed with co-transport with sodium. You should know that conjugated bile acids are reabsorbed by co-transport with sodium. Deconjugated and dehydroxylated bile acids are absorbed by passive diffusion. The major secondary bile acids are deoxycholic acid and lithocholic acid. So what were the primary bile acids? Cholic acid, phenodeoxycholic acid. The secondary bile acids are deoxycholic acid and lithocholic acid. All right. Now, this absorption of bile brings us to an important point, which is the enterohepatic circulation of bile. So the liver synthesizes about 600 milligrams of bile each day from cholesterol. 95% of that is reabsorbed and goes back to the liver, as we said, to get conjugated again and excreted into bile again, right? This actually reduces the workload for the liver because the liver doesn't have to synthesize new bile every single time. That's why you reabsorb most of the bile you make. You reabsorb 95% of the bile you make to decrease the workload on the liver. This is shown here. The synthesis in the liver is about 600 milligrams per day. Then 95% of that is reabsorbed into the liver. Sorry, can you repeat the previous slide? About deconjugation and dehydroxylation. We said that primary bile acids are, yeah, sure, no problem. We said that primary bile acids are synthesized by hydroxylation and conjugation, which makes them water soluble. Bacteria deconjugate and dehydroxylate bile to make it more lipid soluble or more hydrophobic. These hydrophobic secondary bile acids, deoxycholic acid and lithocholic acid, are reabsorbed in the ileum and in the colon by passive diffusion because they can pass through the membrane. The bile, the remaining bile, which doesn't get deconjugated, is absorbed by co-transport with sodium. All right, these are the two important points you need to know. Deconjugated and dehydroxylated bile acids are passively reabsorbed. The conjugated bile acids are reabsorbed by co-transport with sodium. All right. Then we discussed the enteric hepatic circulation of bile. Now, eventually, what can happen is there are some diseases. Why is this enterohepatic so important? Enterohepatic circulation so important because there are certain diseases which can impair or block the reabsorption of bile in the ileum. So, for example, some of you may have heard of inflammatory bowel disease or Crohn's disease. What this does is that Crohn's disease involves inflammation of the ileum. The ileum gets inflamed and it can't reabsorb the bile. That means instead of 95% getting reabsorbed, a lot of it goes out into the stool. This means the liver has to synthesize bile again from cholesterol, and it increases workload of the liver. Eventually, the liver fails to keep up with this workload, and the liver starts to synthesize low amounts of bile acids. Hence, this gives rise to fat malabsorption or steatorrhea, right? So that's why the enteric hepatic circulation is so important, because there are certain diseases which can affect the ileum and impair this enterohepatic circulation and cause, in the long term, steatorrhea. All right. Another example would be patients who need their ileum removed by surgery. Some people have ileal resection. These guys can't absorb bile acids, and so they will have steatorrhea or fat malabsorption because of low bile. All right. So now this shows you how bile synthesis is regulated. When you have high levels of bile acid in the hepatocyte, i.e. the circulation is working well and the bile is enough in the hepatocyte, this will inhibit 7-alpha hydroxylase and stimulate bile salt export protein. What will happen is bile synthesis will be inhibited and bile secretion into the duct will be stimulated, right? So high levels of bile basically tell the liver, you don't need to synthesize bile anymore. So let's secrete the bile into the duct by increasing bile salt export protein, and let's stop synthesizing bile. So 7-alpha hydroxylase, which is the rate limiting step, gets inhibited. All right. In contrast, the reverse is also true if you have low levels of bile in the hepatocyte. For example, when the enterohepatic circulation is disrupted, this will cause low levels of bile in the hepatocyte and will tell the liver to use cholesterol to make bile. So the liver will stimulate 7-alpha hydroxylase and it will inhibit bile salt export protein. What diseases causes high levels of bile in hepatocytes again? There's no disease that's the normal situation. Bile should be high in the hepatocyte because of the enteric hepatic circulation. When the bile is low, that's a problem because that means enteric hepatic circulation is not working well because of Crohn's disease or inflammatory bowel disease or someone who had his ileum removed by surgery. That means the ileum isn't working well and bile acids in the liver are low. The workload on the liver is increasing. All right, so the normal situation would be something up here, right? This would be a pathologic situation. When BSEP is stimulated, bile will be secreted into the duodenum. No, look, let me just go back here. This is BSEP. This is the hepatocyte, and this is the canaliculi. BSEP is responsible for secreting those conjugated bile acids into the bile duct, into the intrahepatic bile ducts. Okay? The thing which releases bile into the duodenum is the sphincter of Oddi. So we are done with bile now. So this is a case of a 36-year-old woman who had to have her ileum removed following a perforation caused by severe Crohn's disease. So she has severe inflammation in her ileum that basically necessitated that her ileum be removed. Her post-surgical management included monthly injections of vitamin B12, because you guys know that vitamin B12 is absorbed in the terminal ileum, right? After surgery, she experienced diarrhea and noted oil droplets in her stool. Why did she experience diarrhea? We discussed it in the previous slide. Why is she having diarrhea and fat in her stool? Why is she having fat malabsorption?
Low bile
There's
levels.
a problem in the enterohepatic circulation. Bile isn't
Yeah.
getting recycled.
Yeah, exactly. So eventually her bile isn't getting recycled and her liver isn't able to keep up with the demands of biosynthesis. That means bile, the concentration of bile will go below the critical micellar concentration. And so they won't form micelles. That means it will give rise to fat malabsorption. All right. Why diarrhea? Because if anything which stays in the intestine holds on to water, and it causes an increased bulk in the intestine. You learn more about this in third year, but any food which is not absorbed, it holds on to water and it causes distension of the intestine or stretching of the intestine, and that stimulates motility of the intestine, right? So that's why she has more bowel movements and more diarrhea. Okay, so now let's move on to gallstones. So we talked about how phospholipids and how bile acids are amphipathic, right? So they have a hydrophobic portion and a hydrophilic portion. On the other hand, cholesterol is only hydrophobic. The cholesterol is found in the inside of my cells, right? The problem arises when you have low bile acids or low phospholipid or very, very high cholesterol. That means that the hydrophobic parts of cholesterol won't get solubilized by my cells. Normally, cholesterol should be present inside my cells. But if the cholesterol is too much, or there is an imbalance between cholesterol and bile acid, the cholesterol will precipitate out of my cells and form gallstones. Okay, so this is what it tells you here. Cholesterol gallstones develop when cholesterol concentration exceeds the ability of bile to keep it in solution inside the micelle. When cholesterol is too high, it will precipitate and aggregate together because it's hydrophobic and form gallstones. So this is the process behind gallstones. There's supersaturation of cholesterol because of high cholesterol. Then there is nucleation. Basically, cholesterol precipitates into crystals here. This is nucleation. These nuclei of cholesterols will aggregate and collect to form a small stone. This stone will increase in size to form a gallstone, all right? So nucleation, microstone formation, and gallstone. Now, it's not that high yield a diagram for you to know. This is basically telling you the balance between cholesterol, phospholipid, and bile, okay? This is the normal phase here. As you can see, cholesterol is here. So cholesterol in phase one phase, is very, very low. Bile salt is very, very high, and phospholipid is very, very high. That means all of that cholesterol is solubilized in my cells. But what happens when you go this way to the diagram, to the top left? Cholesterol increases, phospholipid decreases, right? As you're going top left here, to the left, up and up here, cholesterol is increasing, phospholipid is decreasing. This promotes the phospholipid and bile salts form my cells, but the remaining cholesterol actually gets supersaturated and forms gallstones. So this is basically what I showed you, which is an imbalance between cholesterol and bile and phospholipid promotes gallstone formation. All right. Now, this is an important thing which you guys should know. this is basically shows you when a gallstone does develop. So now you have a gallstone, now you have formed gallstones. How will the patient present clinically? How will the patient present clinically? If a gallstone is here in the gallbladder, it won't cause anything because it's not obstructing the gallbladder. If it gets stuck in the neck of the gallbladder, when the gallbladder contracts, it won't be able to empty out bile and it will stretch. And you will have infections with the gallbladder and that will cause inflammation. Okay, so patient will present with inflammation of the gallbladder. Will this cause an impairment in duodenal delivery of bile salts? It won't cause an impairment in duodenal delivery of bile salts because bile coming from the liver can go into the duodenum. All right, so you don't need the gallbladder bile to allow for normal fat absorption. The liver bile, the bile coming from the liver here, is enough to deal with fat absorption. That's why, for example, patients have many people have their gallbladder removed and they don't develop steatorrhea because the bile coming from the liver is enough. So when a gallstone is stuck here in the cystic duct, you won't have steatorrhea. Also, there is far away from the pancreas, so you won't have pancreatitis either. So the consequences of a gallstone in the cystic duct is sludge or stasis and inflammation of the gallbladder, cholecystitis. Right? If the gallstone is stuck in the common bile duct, will this affect duodenal delivery of bile salts? It will, because the bile coming from the liver isn't able to go out either. So patients will have steatorrhea. Patients will also have cholecystitis because the gallbladder is stretching, and they will have something called jaundice. We'll look at that later on. Basically, bile contains bilirubin, and bilirubin needs to go out into the duodenum for it to be excreted, right? When there's a gallstone in the common bile duct, bilirubin is stuck. So it spills out into the bloodstream. And high bilirubin causes jaundice, because the problem with jaundice is that, you have a comment? Does bile from the liver flow through the common bile duct? Yes, exactly. That's why the stone affects, that's why a stone in the common bile duct would affect duodenal delivery of bile salt, because the liver bile isn't able to go out into the duodenum, right? So back to jaundice, we were explaining that bilirubin accumulates in the blood, all right? And bilirubin is a yellow pigment. And the problem with jaundice is that patient's skin becomes yellow and their eyes become yellow. So jaundice is caused by an accumulation of bilirubin, because bilirubin isn't able to go out into the duodenum, right? Will these guys have pancreatic abnormalities? They won't have pancreatic abnormalities because the pancreatic duct is here. The last scenario is that if a stone is stuck here near the sphincter of Oddi, now these guys will have pancreatitis because the pancreatic enzymes aren't able to go out into the duodenum. So they will have, and they accumulate in the pancreas, get activated and destroy the pancreas, causing pancreatitis. These guys will also have jaundice, and these guys will have steatorrhea, and they will have cholecystitis. All right. So the worst one is here. Over here, you only have cholecystitis. Over here, you have steatorrhea, cholecystitis, and jaundice. Over here, you have pancreatitis as well. So this usually comes up in exams, that they will tell you a patient, for example, there's a patient who presents with epigastric pain radiating to the back. She has jaundice. Automatically, you know that the stone is stuck here. All right. Can you explain what causes steatorrhea again? Steatorrhea, anything which steatorrhea is defined by fat in stool. All right. Fat is usually absorbed. When there's fat in stool, that is called steatorrhea. So anything which impairs or blocks fat absorption causes steatorrhea. That cause could be obstructed bile delivery. So bile is not getting out into the duodenum and fats aren't being absorbed. That could cause steatorrhea. Another example of steatorrhea would be chronic pancreatitis, because the pancreas releases lipase, right? If the pancreas in chronic pancreatitis, the enzymes are insufficient, you go into a state of pancreatic insufficiency. So lipase isn't being secreted. That gives rise to fat malabsorption, causing steatorrhea, right? Anything which causes fat malabsorption causes steatorrhea. Okay, does this slide make sense to you guys?
Why doesn't a blockage in the common bile duct lead to hepatitis as well?
So there's something you learn about it later on called biliary cirrhosis and cholestasis. All right. So hepatitis would result from inflammation in the liver and causing an increase in AST and ALT. This would block bile flow, and this would cause cholestasis. So the symptoms are totally different, and the lab findings are totally different. There are certain diseases like there's something called primary sclerosing cholangitis and other diseases. They chronically long-term cause blocked bile flow and cause bile to build up in the liver. They will cause cirrhosis. But a gallstone is quite an acute problem. It won't cause cirrhosis straight away. Cirrhosis takes years to develop. And a patient who has a gallstone in the common bile duct, he won't stay at home for years. He'll present to the hospital immediately. All right. So a stone wouldn't usually cause cirrhosis. Chronic problem like an autoimmune disease would cause cirrhosis.
Makes sense. Thank you.
All right. So this is an important slide. They asked us a few questions on this. This is a guy with jaundice. Let me quickly explain jaundice to you. You see this guy, this guy's skin is yellow. The white of his eyes is called the sclera. That's also yellow. This is caused by an accumulation of bilirubin. All right. So let me just make sure you guys understand. So imagine this is a red blood cell, right? The red blood cells have a lifespan of about 120 days, right? You guys should know this from biochemistry. Then they release their hemoglobin. Hemoglobin is converted to bilirubin. Okay. Bilirubin goes to the liver, and in the liver is secreted in bile. If you can understand this flow, you will understand the causes of jaundice. Let's say there's increased breakup of RBCs. RBCs are breaking up. In biochemistry, you guys took G6PD deficiency and pyruvate kinase deficiency. They cause death of red blood cells. If there's a lot of red blood cells dying, that will result in high release of hemoglobin into the blood. That will increase bilirubin. This bilirubin will cause jaundice. So this scenario, let's call it 1, is called pre-hepatic jaundice because it's happening before the liver. Okay. The second one is cirrhosis. So if the liver isn't able to use that bilirubin coming from the red blood cell and secrete it into bile, that bilirubin will accumulate, causing jaundice. This is hepatic jaundice. If, for example, the liver isn't able to secrete it into bile, or the bile isn't able to go out into the duodenum, right? Because of a stone. Let's say this is a stone here in the common bile duct. The bile will build up in the liver, and bilirubin will build up in the bloodstream, causing jaundice. So this is post-hepatic jaundice, number 3. So pre-hepatic jaundice because of hemolysis, because of G6PD deficiency, for example, or pyruvate kinase deficiency. Cirrhosis causes hepatic jaundice. Gallstone would cause post-hepatic jaundice. Okay? So that's what I've told you here. Jaundice is defined by yellowish discoloration of the skin and sclera. The white of your eyes is the sclera. All right, when that turns yellow, it's called jaundice. Jaundice is caused by an accumulation of bilirubin, which is yellow. Pre-hepatic jaundice results from hemolysis or breakup of RBCs. The causes you should remember from biochemistry: G6PD deficiency, pyruvate kinase deficiency. Hepatic jaundice is caused by cirrhosis because the liver isn't able to deal with the bilirubin coming in. Post-hepatic jaundice would be a stone in the common bile duct. All right. This is a question for you guys to answer. Can anyone read this question? Khalid, you've been participating.
All right. A 41-year-old woman comes to the emergency department because of an 8-hour history of abdominal pain and nausea. The pain worsened after she ate a high-fat meal. Physical examination shows scleral icterus and diffuse tenderness in the upper abdomen. Serum studies show elevated total bilirubin, alkaline phosphatase, and gamma GGT. Ultrasound is most likely to show a stone located in which of the following structures? Common bile duct.
Yeah. So if it was a stone in the pancreatic duct, what other thing would you expect?
Pancreatitis.
Pancreatitis.
Yeah, exactly, yeah. So in the scenario, they would tell you that a person is coming in with severe abdominal pain, radiating to the back, and in the lab values, they will show you elevated amylase, right? Pancreatic amylase would be elevated. If it was a stone stuck in the gallbladder neck, this patient would present with cholecystitis. She wouldn't have jaundice. Scleral icterus, this basically refers to yellowing of the sclera, the white of your eyes. When that turns yellow, that's called scleral icterus. That's a sign of jaundice. All right? So we're done with this lecture. Does anyone have any questions? What about B? The common hepatic duct. A stone wouldn't be in the common hepatic duct. So let me show you why. All right. See, this is the common hepatic duct. A stone would form here. So the only way a stone could go is down, right? So it gets lodged in the cystic duct, common bile duct, and the ampulla here. It can't go up and lodge into the common hepatic duct. The common hepatic duct is above the gallbladder, right? Okay, so any other questions? So from this lecture, just remember this step, 7-alpha hydroxylation. I'm just going to tell you what usually shows up in exams. Common bile would be post-hepatic jaundice. Yeah. So let me just summarize to you the important stuff from this lecture. Remember that the rate limiting step of bile acid synthesis is by 7-alpha hydroxylase. The point of synthesizing bile acids is basically increasing water solubility. All right. You should know that bacteria deconjugate and dehydroxylate bile in the ileum and in the cecum. You guys should know that. You guys should remember this protein here, bile salt export protein, causing release, secreting bile into the canaliculi, because this is an example of primary active transport. This came in our GI exam. I remember that. Which one of the following is an example of primary active transport? All right. So you would say bile salt export protein. You should remember the action of secretin. It increases surface CFTR and increases chloride and bicarbonate secretion in the bile ducts. You guys should remember that the gallbladder absorbs sodium chloride and water and concentrates bile. You guys should remember, this is very important for you guys to know, these mediators, acetylcholine, VIP, and NO at the sphincter causing relaxation. You should also know that the neural mechanism or the vagovagal reflex is the major mechanism of CCK. The direct effect of CCK on the gallbladder is quite minor.
This process is only in the intestinal phase, right? The CCK process.
Yeah. The other processes would, in the gastric phase, you would have distension. In the cephalic phase, you would have smell and taste of food. All right. You guys should know that conjugated bile acids, obviously not every single bile acid, primary bile acid, is going to get deconjugated and dehydroxylated. There's some which are going to be left over. Those ones will be reabsorbed by co-transport with sodium, right, in the distal ileum. Then this brings us to the point of the enteric hepatic circulation. You should know that patients with disruption to this enteric hepatic circulation, because such as those with ileum resection, they can develop steatorrhea. The other thing patients will develop after ileal resection is B12 deficiency. You have to know that, all right? Other than that, for this fight, you guys should know that an imbalance between cholesterol, bilirubin, and cholesterol, bile salts, and phospholipids will cause gallstones. This is called lithogenic bile. All right. From here, you guys should really be good with this presentation here. If a gallbladder is stuck in, if a gallstone is stuck in the cystic duct versus the common bile duct versus the pancreatic ducts as well, or the sphincter of Oddi here. All right. This explanation of jaundice, I just used it to make it easier for you guys. If you guys will take jaundice, we took jaundice. I don't know if you guys do take jaundice. So this was just an explanation of jaundice, all right? Remember that something like this scenario would be likely in your exam. That's it. Any other questions?
I have a question.
Yeah.
Can you go back to the micelles slide?
Micelle slide.
Yeah, micelles.
All right.
Like, aren't there some hydrophilic particles inside the hydrophobic portion? Like the green circles, or
yeah. Sure. So we discussed that bile salts and lecithin and phospholipids are amphipathic. This green stuff is hydrophilic. This is pointing out into the solution, because the solution obviously is water, right? So you need something which is hydrophilic to solubilize the solution, solubilize micelles in the solution. The hydrophilic portions point outwards into the solution. The hydrophobic portions point inward. Similar to, for example, if you think about a phospholipid bilayer, the hydrophilic portions point outwards, right? The hydrophobic portions are inward in the cell membrane, for example. It's the same thing here. It's a lipid layer with hydrophilic portions pointing outward, hydrophobic portions inside. The products of lipid digestion. There are some hydrophilic stuff, like some regions of fatty acids are hydrophilic, or phospholipids are, and fatty acids or glycerol, for example. These are digestion products of lipids. These are hydrophilic. They are also inside here. All right. Does that answer your question?
Yeah, so like I guess products from fat digestion, which are hydrophilic, can also go inside based on the second picture.
Yeah. You see something like this.
Okay,
All right.
I see. And also for the last question that we did, you said the reason it goes to the bile duct is because that's the first duct that comes after the gallbladder.
Yeah. So the gallbladder empties into the cystic duct, and then it reaches the common bile duct, right?
Oh, okay.
Here. Here. So this is the this is the cystic duct. This is the common bile duct, right? So if a gallstone is here, the person wouldn't have any symptoms, right? Because the gallstone isn't causing any obstruction. Over here, it can lodge in here and cause an obstruction. It can, and this would cause cholecystitis, but no jaundice or steatorrhea. Over here, if it lodges in the common bile duct, you would have cholecystitis, but also steatorrhea and also post-hepatic jaundice, right? If it lodges here, you would have pancreatitis as well.
Oh, okay. Okay. Thank you.
All right, no problem. All right, thank you. No, my pleasure.